Good morning, everyone. Nigel Giam here, Lead Training Program Director for the St Mary's scheme and RCA trainer for HEE London. I'm really happy to have Munraj on this morning to talk about his approach to the RCA. Really good to see you, Munraj, after the course. And firstly, huge congratulations with that massive score in the RCA. You must be very happy.
Yeah, really happy. In all honesty, I was a bit lost before doing the course, and then everything came together quite nicely. I learned a lot from you, and it helped me focus my kind of last 5 weeks, I think, before I submitted. So yeah, thanks to you. Big part.
No problem at all. Well, thank you so much. That's really kind of you. I know we had a bit of email contact around specifically case selection, and I thought maybe we could focus a bit of the interview around that. I mean, how did you find in terms of case selection, firstly, selecting the cases in your practice, and then the second thing being choosing the right ones?
So I initially struggled, kind of just seeing what came in, and trying to pick cases off, or actually just letting the reception book into my list. And that was a bit of a potluck, and you'd have some good days, some terrible days where you record 10 and get nothing useful. And so then we changed our tack, and we actually agreed with the practice that I would be able to block my list every morning. So my book on the day slots were always blocked, so for the morning clinic. And then I was allowed to go and cherry pick off other cases, off other lists, which made life a lot easier, because then you knew what you were looking for, and could then, if you were recording, say, 5 cases that morning, you had a chance of 3 being good, or at least some were usable. Then in terms of specific case selections, I looked at the criteria, the mandatory criteria, and obviously you then look at your acute case and think you're looking for a chest pain, a shortness of breath, a calf pain, and then the pediatric cases. Again, you were looking for an abdo pain, or an unwell child, looking at the 0 to 1s, which were coming in every day, always on duty. There's always some there, and then for the female health stuff, I found HRT, which initially is a really challenging case when you first start, because you just got so much information to get in such a short time. But then as you do more and more of them, I actually started to stop recording them because I thought they were too difficult. Then I thought, actually just keep going, and you find you get a patter and you get to rattle off the benefits, the risks, everything really quickly. And then you'll also find some patients come with an idea already, and that makes your life a lot easier. The ones who come and say, I have no idea about HRT, they're difficult because you've got too much to give. But some will say, no, I'm really set on a patch, my best friend has one. Cool. You can go in straight away. And so that's really how I did it. Like I said, I probably recorded over a course of about 8 weeks. So a shorter time period than a lot of people, because I decided to sit early, but I decided late. And I found just focusing in was really useful, and using the practice and coming up with an agreement with the practice that I was allowed to pick my cases made life a lot easier. And I know not everyone had that freedom.
So that's a really important theme, actually, isn't it? Because it takes time to negotiate with practice to actually pick the right case, cherry pick, and have that protected time. Practice makes perfect. So you specifically highlighted that HRT aspect. And if a patient's got that kind of set agenda to start on it, that makes a better case, doesn't it? Because you can actually make an informed choice, make a management decision, and actually make sure that your patient understands the risks and benefits around that, so that you can come to a shared decision. I suppose moving forwards, what would your kind of biggest take-home message be for those who are sitting or having to resit this autumn?
So number one would be the negotiation with the practice. So when I, like I said, and from speaking to other people, I was at that point when I was in my stage of training, I was on 15-minute consultations, and I found having 15-minute consultations to prep, do your 12 minutes, and if you'd overrun, then document, and then also just unwind, because it's stressful, because you're switched on for 12 minutes really intensely, compared to a normal clinic where you can be a bit more relaxed and you're kind of looking around and not focusing in that same way as an exam. So I found it difficult. So I then agreed with the practice we'd halve my time. So we went down to I went back to 30-minute slots, so that I could then have my time to do everything. And I know that's a luxury. I know I was very lucky, very well supported. So that was useful. And if you can get that agreement, then it sets you up pretty well. then other than that, when it comes to actually case by case and about leading off the course, that first minute, I initially used to go through a classic history of kind of medical school history and trying to work my way through, and it just doesn't work. And it's not the point of the exam. And that golden minute, let them talk, then get their ICE and their psychosocial side of it, and be really open about it. Don't feel shy about saying, open on questions about ICE. How is this affecting you? Really tick those boxes for the examiner. And then once you've got that, the next 7-8 minutes, you can just hone your data gathering based on why are they worried it's cancer, why are they worried about it. And then your clinical management, you can answer their questions, you can tell them no, of course it's unlikely, and then you get all those marks, and then you finish off, you can round off quite nicely.
I think you've hit the nail on the head there, which is that we've talked so much about this, haven't we, on the course, the second golden minute, and actually following through on the patient's ICE and using it so we can come to an informed choice at the end. Nigel, it's been absolutely great to see you again. I wish you all the best post CCT, and I know you're very interested in sports medicine, so I'm sure we'll have you back on our VTS scheme teaching our trainees about sports medicine. Have a great day. Take care of yourself. Thank you so much.
Thanks very much.
All right.
Cheers, Nigel.
Bye now.
Bye bye.
So thanks again to Munraj for his insight with regards to how to pass the RCA. He scored really, really well in the 180s on a first-time sitting with a limited amount of time. Main message is though, you've got to have time in order to prime your case, and really that often will involve negotiation with your practice. So you're picking the right cases. Think about the challenge of the case. Think about the complicating factors which encompass the angle to the case. We've talked a lot on the course about the second golden minute and how to kind of outline where your case might go. Do feel free to have a look at my resources around that and around case selection. So I'm really looking forward to the next interview. We'll try and interview a range of ST3s. Again, do look at the website, mentormededucation.com, for further resources. Have a great day. All right, take care. Bye now.